Thank you. I will present this morning autosomal recessive muscular dystrophy in Tunisia, and particularly the clinical phenotype and molecular genetic aspects. Working on genetic of neuromuscular disorders since many decades, this drew our attention on the presence of some particular disorders that are frequent in our population and very rare outside the region. And to make my presentation more clear, I would like to summarize some elements of the origin and the history of North African population, some historical element about this population in North Africa. Indeed, the human history of North Africa has been shown to be complex demographic process, characterized by multiple migration, admixture, and founder effect. The first occupation of the area by modern humans may be dated back to so long times, 160,000 of years. But we think that the region had been occupied since 10,000 of years. One of the most prevalent human groups of this area are Berbers, who are supposed to be descendants of this first migration back to Africa. It was well known by people working on this area, and they came from Middle East. However, things in reality was more complex, and genetic evidence appears to indicate that the most Tunisian or North Africans were, even if they were considered themselves as Berbers or Arabs, are predominantly of Berber origin, and that ancestral Berbers have been in the area since many years in the upper Paleolithic area. But there is some other characteristic of Tunisian population. Nomadism is one of the factors that has contributed to the geographic isolation of this Berbers population. Sometimes they are Numidians. And however, also significant proportion of both Berbers and Arabized, they became Arabs. Berbers gene pools derived from more recent human migration, and it was melted with Indo-European, Semitic, Germanic, and Sub-Saharan African people. All of these have left some genetic footprints in the region. It is interesting to understand what's in Berber. Berbers means in Greek, speaking foreign language, and it became Berber after. Therefore, in this slide, I summarized all the major historical origin and occupation that occurred in Tunisia. And very quickly, as you can see, there is first Carthage, who have predominant in Tunisia in 264 BC. And after the fall of Carthage, there is the apogee of Rome in 150 BC, and Rome occupied all the Mediterranean area. After the fall of Romans, Vandals came from Germany and came to Tunisia for 200 years until the Islamic conquest. After that, we have the Ottoman and more recently the French colonization. All this today to say that Tunisia have very rich genetic background mixture. This mixed origin population, Amazigh, what means diverse, Phoenicians, Romans, Mongols, Arab, Turkish, European, with the high rate of consanguinity, give to Tunisia this kind of the pedigree that you can see, and the raising of some particular neurological diseases, and in particular, muscular dystrophies. Tunisia is a small country, as we know, with a population around 11 million, and there is slow rate demographic growth now, but rural population is still important in this country. This kind of things make that it's easy and give good opportunity to study neurogenic disorders in Tunisia, because the family is still large. There is improvement of public health indicators, good neurological expertise, and the proximity of public health structure to the population. I worked for 3 decades or 4 decades in what we call it now Institut Mujib Hamida of Neurology, and for 3 decades I was the head of the Department of Neurology, which have many units, the patients or patient neurophysiological and neuromolecular laboratory. And thanks to all my collaborators, we focus on neuromuscular diseases since 1980. This allowed to our lab to describe new diseases in Tunisia in the literature. Tunisian muscular dystrophy, juvenile and recurrent sclerosis, ataxia with vitamin E deficiency, and
سامحني سي فيصل باش نقص عليك، سامحني هونيك كيف بعدت شويه على الاكران الصوت طاح، دونك يا اما اقرب انت شويه فوالا لو كانت نجم تعاود لنا السلايد هذه avec un son plus fort.
We focus since 3 decades, thanks to our collaborators, on the genetic diseases and neuromuscular diseases in Tunisia. This allowed us to describe diseases such as muscular dystrophy, juvenile amyotrophic lateral sclerosis, ataxia with vitamin E deficiency, LGMD2I, some form of Parkinson, familial Parkinson, and some form of new forms of ataxia. Also, and thanks to our lab, we have been able to map the gene of 15th disease and identified the gene of some of them, as you can see on the slide. I will summarize our work on muscular LGMD, which is autosomal recessive muscular dystrophy in Tunisia. Indeed, the first description of muscular dystrophy go back to 180 years by the so-called Duchenne, who is French, and Duchenne muscular dystrophy is the most prevalent muscular dystrophy in the world, since this disease affects only boys with around 1 boy on 2,500 newborn boys. And it was linked to chromosome X, which means that only boys were affected. In 1954, Sir John Walton and Madras identified a new group of disease that they call it LGMD, which means limb girdle muscular dystrophy. And as illustrated in this quote from the original paper, and that I will read, and it says that in our opinion, these cases should be regarded as a distinct clinical and genetic group, and we suggest that they should be coded in limb-girdle muscular dystrophy, leaving aside certain clinical characteristics, which may be added later. We feel that the cardinal feature of this type are onset, date, first, second, or third decade, commencement of muscular weakness in either shoulder or pelvic girdle, and autosomal recessive inheritance. It is important to go to some historical background of this disease. Indeed, since the 19th century, some anecdotal description of severe limb-girdle muscular dystrophy affected boys and girls were reported but not recognized by the medical community. In 1977, my boss, Ibn Hamida, head of the Department of Neurology at this time, and 3 years after the opening of our institute, reported in a French journal the description of 31 patients with severe muscular dystrophy affecting both sex. And he called this as Duchenne fee, what's mean girl Duchenne. And we know that Duchenne usually affect only boys. A second large paper in collaboration with Michel Fardou in Paris described in details this new entity on the genetic histological aspects. In 1987, it was an important date because it is the date where the cloning of dystrophin gene have been made by Conker and his group. And in 1989, there is identification of the protein associated what we call a dystrophin, which is the gene affected in Duchenne. And in 1990, we reported that the dystrophin, which is absent in Duchenne muscles, was present in what we call it at this time Tunisian muscular dystrophy, as you can see on the slide. And we have the hope and we have the chance, the luck, that this chain have been mapped by one of our collaborators, Blanckman, in 1982, 1930. And the gene of LGMD2 and the gene of what we call it Myoshi, we come back to this, by one other collaborator in Tunisia between 1995 and 1998. We mapped it in our lab, another gene of LGMD, and up to now there is more 20 genetic form of autosomal recessive muscular dystrophy. And as you can know, and what I said before, all this group has been not known before the work of Ibn Hamida and his group. What's mean autosomal recessive limb-girdle muscular dystrophy? We call them now in literature LGMD2. They are primary and progressive muscle disorders with autosomal recessive inheritance. I say that there is 20 genes identified, but up to now, the pathogenic mechanism leading to muscle necrosis remain unknown. That's why there is no treatment. And the relationship between the different proteins evolved and remain unknown except for the sarcoglycanopathy that I will explain after. Here on this table, I have summarized all muscular dystrophy which are not Duchenne with autosomal inheritance. When it is dominant and it is very rare in Tunisia, we call it LGMD1. When it is recessive, we call it LGMD2. And there is two groups, sarcoglycanopathy and non-sarcoglycanopathy. And non-sarcoglycanopathy, as you can see, it is very, very, very important group. It started by LGMD2A, alphabetic, until 2T. What means sarcoglycan? Sarcoglycan has a complex of glycosylate transmembrane protein, which is composed by 4 different glycoproteins: gamma, alpha, beta, and delta sarcoglycan. Each of them are mapped to different chromosomes, 13, 17, 4, and 5. The gamma sarcoglycanopathy, it is the Tunisian muscular dystrophy described by Ibn Hamida and collaborators. Clinically characterized by early child onset, progressive course, the muscle weakness and atrophy affect pelvic and after shoulder muscles. There is frequent calciopatrophy. It looks exactly like Duchenne. But what is different from Duchenne, the variable course between siblings with the same mutation. CK is high, and on muscle biopsy, typical muscular dystrophy like Duchenne muscular dystrophy. But in this disease, dystrophy that we can see on this slide here, the dystrophy state was normal and it was absent in Duchenne. Here we can see on this slide the immunohistochemy and of sarcoglycan. And in the Tunisian form, the gamma is absent, the others are present or mildly decreased. That is very characteristic of our disease. And what is also important, that this disease is frequent, as we can even see, all the majority, the large majority of our patients have what we call it linkage, disequilibrium, which means that they have a founder effect. One ancestor gives to all Tunisian muscular dystrophy. There is another mutation in some Libyan patients, which we look to for it when patients come from Libya. And this muscular dystrophy exists in all around the country, in the south, the middle, and in the north. And founder mutations mean that all these diseases all the patients have the same ancestor, what is very important, as we can see. Gamma sarcoglycanopathy, Tunisian muscular dystrophy, is very rare in European population. And we have similar prevalence in Algeria, Morocco, Egypt. Saudi Arabia is probably not gamma, but other in case, you see. Alpha sarcoglycanopathy, LGMD2G. It is the most frequent sarcoglycanopathy in Europe. And it is very rare in Tunisia. 10% of the family in Tunisia have alpha sarcoglycanopathy, LGMD2G. And we published 2 families with 2 different mutations and no mutation. And you can see the difference. Rare disease with different mutation. This alpha. Gamma sarcoglycanopathy, very frequent and only one mutation in all Tunisian population. This will raise many questions for us. The beta is the less frequent than HNK2, and we only see one family in Tunisia, but it remains as frequent in Brazil. And it is also probably very frequent in Sudan and Arab Saudi. But we have not very, very good literature on this. And beta sarcoglycanopathy is have very severe phenotype. And also, it's different from gamma Tunisian muscular dystrophy by the absence of the expression of sarcoglycan on muscle velocity. The delta is very rare, not found in Tunisia and reported only in Brazil. The other disease, we finish with sarcoglycan and we go to other autosomal recessive limb-girdle muscular dystrophies. And it's Mayushi in Japan who reported family with muscular dystrophy, but distal muscular dystrophy. And it was reported also in one family in Palestine. And linkage of this disease on one Tunisian family was made by one of our collaborators, Mrs. Joey, in 1995. And the gene had been identified 3 years after by Tunisians and other collaboration with American groups. The other forms that have been reported in Tunisia is LGMD2I. First reported in Tunisia with linkage in 2001. But what is very important for the disease, that it is the most frequent autosomal recessive limb-girdle muscular dystrophy in Europe. But in Tunisia, it remains very rare, and we reported it on only one large family from the sample of Tunisia. The difference with gamma sarcoglycanopathy is it is less severe, started usually the second decade, and the gene involved was FKRP, ubiquitin-related protein. And of course, we found the genes, we reported the mutation of the genes in the paper by Dr. Rima Mori, and we found different mutations that others that found in Europe. To summarize, where we are in limb-girdle dystrophy. We finished the work? Not yet. We have around 1,200 patients. 38% are Duchenne. As I said before, in the beginning of my presentation, that Duchenne is the most frequent muscular dystrophy in Europe, but it is less than the half in Tunisia. The majority of autosomal recessive muscular dystrophy in Tunisia are LGMD2 with autosomal recessive inheritance. When we go to molecular genetics, only 60% of patients have been identified. What means? Means that is 40% of patients remain without known gene. What means? There is a lot of work for the future generation to find the gene of all these diseases. And as you can see, LGMD2C, which is Tunisian muscular dystrophy, is the most frequent, representing 75% of all patients, and the others remain rare, but 40% remain to be discovered. We have some problems with LGMD. First, intrafamilial phenotype variability. Second, epidemiological repartition, because we found it all around Tunisia, even if they have the same mutation. Third, genetic counseling is difficult because sometimes we have intrafamilial genetic heterogeneity. Intrafamilial phenotype variability is something that it is very important to know, because probably there is a modifier gene which make the disease severe or less severe. In the same family, we can have, as we can see, patients who have blood building in when he is 12, and others still walking, and they are 16 or 16 years. And this variability, even if it is the same mutation on the same gene, have not good explanation. Maybe there is environmental factors, but we know that environmental factors are not good, because some variability found in the same family, between siblings, living in the same condition, eating the same things, but the disease is very variable from one to other. Maybe why it is so prevalent. As we can see, the Tunisian muscular dystrophy is very severe. These patients cannot be married and have children. Why the disease remains so frequent in Tunisia? Maybe there is some selective advantage of this mutation, but of course we have to demonstrate this one day, probably by young neurologists working now in the institute. Second difficulty of this, and what's make things more difficult for molecular genetics, that it is very difficult to give genetic counseling if we didn't do all the genetic tests of all the family members affected. That is an example. 3 patients in 2 branches of the same family. One have gamma and the other have alpha sarcoglycanopathy. What means? If we find this and we think that we look for the mutation, or for the prenatal diagnosis, we will not find the mutation, and the patients will be affected. What means that we have to be very careful and look for all the genes even in the same family. It is not very rare, this genetic heterogeneity. It's not an isolated phenomenon. This family, large family. Here, this family are absent on this slide and present in this branch. Same family, almost same phenotype. Some have dysphenotypathy, which means Maury disease, and the others have a gene that we have not yet discovered. And this family, we say, 2 comments for this. First, it is difficulty of genetic counseling in embryo population. If you have 1 patient and another in a cousin, we have to be sure and to do the genetic testing and not see who have probably the same disease. What is the significance of such association? It is considered that this is the most logical hypothesis, but this hypothesis didn't have not a good statistical basis, because this disease are so rare, and together in the same family give us a lot of questions. Most important therapeutic approach. We tested prednisone, which are given to the shell, and we do a study then in 2 years. And corticosteroids seems to be good for these patients as Duchenne. Of course, it is not a treatment, but allowed to make the patients less affected for some years. And this allowed us to find that gene therapy may be a very important avenue in the future of muscular dystrophy, since the gene, we do it on one muscle, and the expression of gamma sarcoglycan was positive. Of course, the study was being stopped with political problems in the world, and I hope in the future we can, the young neurologists can finish. Thank you, and with this young girl, she is young, very beautiful woman in Berbers, as you can see. Thank you very much.